All right, so we're going over environmental emergencies. We don't see a lot of the extreme cold or the extreme hot. It's kind of like in between, and it's very few. Again, our learning objectives today is to, in an organized fashion, try to ID and treat any immediate life threats as we go on. In an organized fashion, obtain an accurate history, perform examination, and formulate a diagnosis. And in this organized fashion, we're going to develop a differential diagnosis list and refine that differential diagnosis list along the way. So again, we're not usually here. We don't see a lot of deaths because of altitude illness or altitude sickness. We don't see a lot because of extreme hypothermia or hyperthermia, and those are very far and in between. We do normally see maybe some heat-related illnesses and some mild cold-related illnesses as they may be submerged or left in the cold environment for a prolonged period of time. So we should review a little bit of those. Heat stroke, remember we're trying to maintain a person that has altered mental status, that has been in an environment that seems to be hot. So once they change from normal mental status to decreased mental status, we start to think about that person being a heat casualty already in a heat stroke. Altitude emergencies, we have heat and haze. This is where pressures up there cause fluid to build up in the lungs or fluid to cerebral edema or the brain to swell up in the brain, and we want to rapid descent these patients so that we can rearrange that condition. Other injuries that we talk about here is the diving emergencies where they come up too quickly or they've been down too long without enough time to decompress, and we end up having these nitrogen bubbles end up filling up in joint spaces. Drowning a lot of times is due to our over hyperventilating to try to rid ourselves of a lot of CO2, and then what happens is when we get rid of all of that CO2, we don't seem to have that drive to breathe, and as our oxygen depletes us, we end up submerged and left under water, and we have the drowning, the shallow water blackout. All right, case one. So we're dispatched with Leos to a scene of abandoned building, and there's a male patient there. It's confused and belligerent. We think maybe it could be alcohol, it could be drugs, it could be something else other than the environment. But what is it like? It's 3 a.m. in the morning, there's some rain, and it's 50 degrees Fahrenheit. So it's cold, and it could be many different things going on, but that's the idea, is you want to start to flood yourself with a lot of different concepts and differential diagnoses and slowly take this out. AMLS pathway is there for us to stay organized. Scene should be safe at this point because we have local law enforcement on scene. We may take some PPE or what we need, but let's take a look at what we got. So our eyes, as we look over, our first view of our patient is an elderly person kind of mumbling. Could this be stroke, alcohol, smell, urinating on himself, okay? And he's not wearing any kind of protective warm weather gear. This could be an issue for that gentleman, especially in that age presentation. We might be looking at some chronic degenerative illnesses, poor health status already to begin with, and he's altered, mumbling, alcohol. Is this because of hypothermia? Is this AIU tips? Is this some kind of neurological event? Is this drug related? Is this environmental related? Is this something else, a metabolic condition? He's awake, mumbling, airways open, there's some bronchi. Skin's pale, it's cold, he's shut down. The environment's probably causing the veins to constrict, his respiratory rate has to compensate. He's not ventilating well, he's got some kind of issue with his lungs. And as that happens, he's not able to get oxygen levels in there. What will be some of our diagnoses? We've been thinking about it already. There could be a lot, being stroke, hypoglycemia, drugs, seizures, toxins. It could be an infection somewhere. We need to get more information, so we dive into our HPI, or we can get into our sample, or we can try to do some diagnostic stuff by doing an assessment. If I go right into our OPQST, our history of present illness, really not getting much there. He was at a pub about an hour ago, so he hasn't been out in the environment that long. He's not on any meds that he knows of, but he looks like he may be a diabetic according to medical bracelets. You can smell the AOTB. Bystanders say he left an hour ago from the bar. Some of our secondary vital signs and secondary surveys. So we got a heart rate of 60, which you would think he'd try to be compensating. His pulse ox is way too low. So it might not be registering or reading. Here we have an EKG strip. Again, it kind of falls within that range. His respiratory rate, if he is at a SAT of 68, he should be either unconscious and on some kind of narcotics to cause him to be breathing so shallow. These numbers are just not jiving. So they are trying to confuse us here. Blood pressure is 102, temperature is pretty low. We want to get this guy out, and at least don't treat the machines, but treat your patient and get him on some of those, get him out of the environment, get him warm. Here we got some of our secondary exam, and we're looking at the patient. Is this mostly environmental or is this alcohol? Now, alcohol can cause an environmental issue as well. Let's get our blood sugar and EKG and the like. So we have blood sugar elevated, sinus tachycardia in the 60s. It's not a sinus tachycardia if it's in the 60s. So we have sinus rhythm in the 60s, so it's not compensating. The 12 lead shows some Osborne waves. It just means that it might be a little cold. You consider a metabolic panel. Yes, we're going to see if there's blood, anything else in his system. He's got alcohol positive. So they're already showing us that he does have some of those. It's only to tell us that maybe there's some issue, not necessarily a major finding. So what do we do about this patient? Remember, this is usually referred to Osborne waves with hypothermia. So that's their J point as we look up here. All right. So you can see at the back of that QRS complex, we can see those notches coming down. 2-3 AVF all the way to the AVL. All right, so let's move on. What our diagnosis is, what else could it be? Yep, we're gonna stick with our initial, but as we get through this is your initial, but what do you guys think is gonna be? What is our ALS, let's go with our BLS. What is our BLS treatment gonna be? What would we consider our ALS interventions? What are we gonna do for our critical care? What else do we need to do? What else are we looking for? What do we think is going on? So we need to make sure that our patient, if this is a hypothermia and they're not, we got to do something about it and think about what we would be doing to curb and treat this.